Copyright Stanford University, all rights reserved.
Moving on to our next speaker is Steve Roth, who's the chief of the Pediatric Cardiology Division here at Stanford, and he previously trained at Yale University for his doctorate degree and also MPH at the Harvard School of Public Health. He subsequently went through and completed his residency and also his pediatric cardiology fellowship at my former stomping ground, Boston Children's, and then subsequently was faculty here at Stanford and quickly risen to full professor and is the James Baxter Woods and Yvonne Craig Wood Endowed Professor of Pediatric Cardiology. He's also received numerous awards, including being the president-elect for the Western Society of Pediatric Cardiology, is on the board of director for the Pediatric Cardiac Intensive Care Society, and he's going to be telling us about the Children's Heart Center and the Lucile Packard Children's Hospital. Thank you, Steve.
Thanks, Sean. Thank you also, Joe and Ingrid, for the invitation to be here today. What I'd like to do in this brief overview is give you a sense for the clinical operations and the clinical program in the Children's Heart Center at Packard and our Division of Pediatric Cardiology, to talk about those faculty who are engaged primarily in basic research, to talk about those who are doing funded clinical research, and then what our priorities are and program development plans over the next few years. So our center is what's called a Center of Excellence at Packard, and it was established in 2001 at the time that Frank Hanley and Mohan Reddy, two outstanding pediatric cardiac surgeons, were recruited from UCSF here. This was done primarily with resources through a major fundraising effort at Packard through the foundation called the Children's Health Initiative, and it also funded the hire of a number of other leaders in the program over the last 10 or so years. Since Dr. Wu showed the progression of cell phone technology over time, I'll also use that as an example of where we have come from in 2001 to now in terms of the size of our program. Our faculty in cardiac surgery based here at Packard has grown from 1 to 4 attending surgeons. The pediatric cardiology faculty, which was led by Dan Bernstein at that time, has grown from 5 to 32 members. We now have 10 pediatric cardiac anesthesiologists, a group of radiologists who focus primarily on cardiovascular imaging and in pediatrics and pediatric radiology. We have a new 20-bed CVICU that opened several years ago after having been based in the PICU as a place to deliver cardiac intensive care, and the surgical volume has now grown to a little over 600 total procedures a year. We're also part of a network now. Dr. Hanley had developed affiliations with other centers when he was at UCSF. So there's been a long-standing association with Children's Hospital of Central California, which is in Madeira, with Children's Hospital Oakland, and with Sutter. And so these are programs that have surgeons that, in this case, were all trained by Frank and Mohan, who are based there locally. And Frank and Mohan each go, typically 1 day a week, to these other programs to help them with case selection, help them with difficult cases, and to essentially administer their programs. So these are long-standing relationships that allow us in total to be doing in the range of 1,100 to 1,200 operations a year on mostly children, of course, with structural heart disease. More recently, Packard has formed a foundation for physicians. It's called the Packard Children's Health Alliance. And in the last 2 years, we've brought in the 3 largest pediatric cardiology practices in the Bay Area, one in San Jose, one in the East Bay, specifically based at Oakland Children's, and at CPMC in San Francisco, so that we now have outreach capabilities throughout Northern California through our partners in this foundation. A couple of highlights about the Children's Heart Center. It first achieved U.S. News & World Report Top 10 status in 2007, and currently in cardiology and heart surgery for children, it's ranked number 8. It's a full-service program, meaning we can deliver essentially all the different current aspects clinically of cardiac surgery and cardiac medical care. and we particularly focus on high complexity and high acuity patients, both surgical and medical patients. And it's become a destination program nationally and internationally for selected surgical procedures. This is based predominantly on Frank Hanley's use of what's called unifocalization for patients with tetralogy of Fallot who happen to have MAPCAs, or major aortopulmonary collateral vessels, and also regionally for subspecialty cardiac medical care. To give you a sense of just clinical volumes in the program, for inpatients, patients who are either primarily cardiac medical or primarily cardiac surgical. This represents data in the fiscal years 10 through 14 for discharges of patients. And we've had a fairly steady cardiovascular surgical volume caseload in terms of discharges, but cardiology has been growing progressively. And just in this last year, for the first time, there were more medical patients discharged than there were surgical patients. In the surgical program, this is a fairly long view, a 7 to 8 year view of procedures and mortality. This is unadjusted for our fiscal year 7 through 14. The volume is fairly stable for procedures, as you can see. Went over 611, and this last year was a little over 600 again. And for most of the years, the unadjusted mortality was in the range of 2 to 3%, with the exception of 1 year, fiscal year 11. If you, however, use the metric that Dr. Dahlman was just talking about, which is an observed to expected mortality ratio, this is data from the Pediatric Health Information Services database, the PHIS database, for 2012 and 13. And our chief competitors, top 5 programs right now, are Children's in Boston, Children's Hospital in Philadelphia, and Cincinnati Children's. And as you can see, in the last 2 years that we have data for, we've had a significantly lower O to E mortality ratio. This is 30-day mortality ratio for surgical patients than our 3 competitors listed here. So this, I think, is what speaks to the complexity and acuity of our patients, and we've done very well despite that high level of complexity and acuity. Our non-invasive imagers who do echocardiography have been increasing their clinical volumes. There's about a 10% proportion of fetal imaging that's done in our program. The majority is transthoracic imaging, with an increasing amount of transesophageal imaging, as shown here in terms of volumes. And then for invasive cardiology, the catheterizers are now typically cathing more than 1,000 patients a year. There are 2 faculty members who do this. A little more than half of our caths are interventional caths. And then in the interventional EP program, the caseload has drifted up from around 200 to about 250 to 260 invasive EP cases a year, with 3 faculty being focused in this area. I'd like to highlight 2 of our clinical programs just to give you a sense for what's been happening in the last few years. The first is called the Pediatric Advanced Cardiac Therapies Program, or PACT program. It's led by David Rosenthal and assisted with 2 of our surgeons, Katz Maeda, who's based here, and Olaf Reinhardt, who's based in Oakland, who both do VAD and transplant surgery. Heart failure occurs in children with structural disease, as well as those who have primary diseases of the myocardium. And currently, we're the only program in Northern California that offers advanced heart failure management and transplantation for children. Children with severe heart failure, like adults, can end up requiring mechanical circulatory support with ventricular assist devices. So we are doing more and more of that therapy now over the last few years. And this program within cardiology and within the Heart Center has been the area of greatest growth over the last 6 years. Just to show you one slide on volumes for ventricular assist devices and transplant case volume. We now put in a variety of devices into children. There's really only one device right now. It's called the Berlin Heart, that can be used in infants and small children. And the other devices, some of which were mentioned, the HeartMate and HeartWare, are devices that we can put into teenagers and adult-sized patients, and we manage them similarly now to our colleagues on the adult side. We try and move patients through the ICU quickly, up onto the ward, and in some cases as outpatients, and manage them as outpatients as well, much like you are doing as adult physicians. So this just gives you a sense for our volume, and actually in the last calendar year, we placed more ventricular assist devices here than any other pediatric program in the country. So this is now one of the biggest programs around. Excuse me. The second program I'd like to briefly mention is the Adult Congenital Heart Program that is based jointly at Packard and at Stanford. Congenital heart disease is the most common birth defect, and now more than 90% of those born with congenital heart disease are expected to live into adulthood. Shaun White is an Olympic gold medalist who happened to be born with tetralogy of Fallot. He's repaired in infancy and has been able to compete, obviously, at the highest level successfully despite having repaired structural heart disease. It's estimated that there are more than 2 million people in the US now with congenital heart disease, and as of 2012, there was an inflection point in that there are more adults who have survived than there are children with congenital heart disease. And there are only about 70 specialty physicians with formal training in adult congenital heart disease in terms of fellowship training in the country right now. So this is an area of very significant growth from a fellowship training perspective, and we've initiated a fellowship training program here within the last year, and our first fellow is engaged in that program now. In Northern California, we, UCSF, Kaiser, and Sutter Sacramento are all actively practicing, and there are estimated to be about 30,000 patients who need to be seen and need to be managed, and probably less than a third of them right now are being seen and managed by individuals who have particular training in this field. So in 2013, we essentially transformed this program from a clinic with one provider seeing patients, Dan Murphy, who's been in our program for years, into a program where we recruited a program director. Her name is Sue Fernandez. She came from the BAC program, the Boston Adult Congenital Program at Children's in Boston. Shortly thereafter, we recruited George Louis from Montefiore and added a second attending, also another person trained at Children's in Boston. And Ian Rogers, most recently from the adult division, has joined us as well. And so we've gone from, again, a clinic to a program where we actually have outreach going on and a significant increase in our overall clinical volume. And in the last 3 years, the growth in surgical volume has approximately tripled from about 25 cases to 74 cases thus far in 2014. And we anticipate continued growth as more referrals are brought into our program, and probably will be closer to 90 to 100 surgeries in this next year. And just so you know, the vast majority of these operations are being done by congenital surgeons, congenital heart surgeons, Frank Hanley and Katz Maeda. And the vast majority of these patients, if they don't have important comorbidities, come to the cardiovascular ICU at Packard for their post-op care. And that's a model that's been used in a number of other programs because of the complexity of the anatomy and the unusual physiologies that these patients tend to have. So that's our current model, and fortunately thus far, we've done very well with it. Our division right now, as I mentioned, has 32 faculty. The majority are clinically focused, and much like an adult division, they're divided by subspecialty into the groups of subspecialty types of practices I've shown here. The majority are in the cardiovascular ICU and non-invasive imaging, but we pretty much have all the significant subspecialties covered by at least one person. 5 of our faculty now have a predominant research focus for their academic time. Our fellowship program has also grown substantially. There are 18 or 19 fellows a year now in training. There are 4 each year in a 3-year ACGME accredited fellowship program, or categorical program, that is fully supported by Packard Children's Hospital. And we take 6 or 7 PGY-7 fellows per year, 2 or 3 of those in the CVICU, and the other 4 distributed across the other subspecialties, just depending on the quality of candidates and where we most see ourselves needing support, and also looking to train people to go into the field in areas that are underserved. These positions are also fully supported by the hospital. So to talk briefly about our basic science faculty, there are 4 individuals: Dan Bernstein, Marlene Rabinovitz, Pilar Ruiz-Lozano, and Sushma Reddy, who are mostly doing basic research. I'll just take you very briefly on a tour of what they're focused on and how they're funded right now. Dan, longstanding member of our faculty here, when he transitioned 3 years ago, took a sabbatical and now is predominantly doing research and has been extremely successful in obtaining extramural funding. He's primarily interested in cardiomyopathy, his longstanding interests in transplant biology and immunology, and has a series of grants that he's now the PI for, both from the NIH as well as from a number of private foundations. Marlene Rabinovitz, who's based within the Wall Center, is one of the world's preeminent researchers in pulmonary vascular development and pulmonary hypertension. Is very well funded from the NIH as well, and is focused on a number of basic science projects and translational projects that again address problems of pulmonary vascular pathobiology and especially pulmonary arterial hypertension. Pilar Ruiz Lozano is a PhD researcher who's mostly interested in myocardial regeneration and the role of the epicardium in development of the heart. And she has been funded both by the NIH and, of note, has recently been awarded a Cardiovascular Institute seed grant for some of her research as well. And Sushma Reddy, who clinically is a cardiac intensivist, now devotes about half of her time to basic research. She's worked in Dan Bernstein's lab the last 4 to 5 years, and she and Dan have developed a model of right ventricular hypertrophy and right ventricular failure in mice, and are using that both to study the physiology of RV hypertrophy and failure, and are looking at the molecular mechanisms on the right side of the heart as well now. And she has recently gotten a fundable score for a K08 in this area. Hopefully we'll find out soon that she's funded for that. She's also received a seed grant from the Cardiovascular Research Institute here. On the clinical side, Jeff Feinstein is involved in clinical pulmonary hypertension and works out of the Wall Center as well. Jeff is funded by the NIH as well as a couple of companies. And Jeff has got a background as an engineer as well, and he has teamed up with Allison Marsden, who did her PhD here, and we're hoping to recruit back to Stanford from UCSD in the next year. And Jeff and Allison and others have developed a computationally based model of a better form of the Fontan operation for single ventricle patients, which has much less shear stress and energy loss within the blood flow patterns of it. This operation has been performed on several children, and they're now in medium-term follow-up to see what their outcome will be. Chris Almond recently joined us from Children's Hospital in Boston. He's a heart failure transplant specialist who's very interested in the development of ventricular assist devices and FDA approval for those devices. He's one of the co-PIs of the Pumpkin trial, the pumps for kids and infants, which will be evaluating new circulatory support devices starting in the next year for children, again, under less than 25 kilograms. Seda Tierney is an echocardiographer who has been working with the Pediatric Heart Network, which is a multi-center trial group that's funded by the NIH. She's in charge of ancillary site studies here in Marfan's disease and ventricular-ventricular interactions. Seth Hollander, one of our junior faculty members who's also in heart failure and transplant, has been investigating the efficacy of group visits for children with heart transplants as a new model for their care in clinic. And he's been recently awarded a Young Investigator Award from the Packard Foundation. My own interests are based in cardiovascular intensive care, where I do my clinical work. I'm interested in trials that are aimed at improving the outcomes of children who have undergone cardiopulmonary bypass surgery. We recently finished a randomized trial using aminophylline to try and reduce acute kidney injury after bypass surgery. We're analyzing the data for that now. And we're about to start an FDA-funded trial, a phase 3 trial at 2 sites plus ours on triiodothyronine, the biologically active form of thyroid hormone, to see if that can improve the response of children after bypass surgery in terms of decreased time in the ICU and decreased time with mechanical ventilation. I'm going to just skip over this last slide to go to where we're heading in the next few years here in terms of priorities and program development. What we intend to be doing, and I've alluded to this already, is to focus especially in the area of heart failure on VAD clinical trials and device development. Again, this is the Pumpkin trial that Chris Almond will be leading. We're also planning to expand our adult congenital heart disease outreach further into Northern California than we have. We've already got 3 outreach sites in operation and hope to expand to at least another 2 to 3 others. We also have an incredible experience, this is primarily Frank Hanley's experience with pulmonary artery reconstruction here, and we hope to put together a bona fide program for this that will combine not only our surgical interventions but also our catheter-based interventions in this area. Single ventricle patients continue to be one of the most challenging groups of children to care for. We have all the resources here to bring together the expertise from fetal diagnosis into adulthood to take care of these patients, and combining that expertise and adding a research component to it is high on our agenda for this next year in terms of program development as well. And then lastly, we recently recruited Doff McElhaney, who's a very well-established outcomes researcher in cardiology, to the program from the East Coast. And Doff is now the director of outcomes research for a new clinical research center that we've started. And he'll be looking not only to help develop some of these programs, but to strengthen our ability to report on our outcomes and to be able to describe what we've done here that's been innovative over the years. Translational and basic science, we will continue with Marlene's leadership here to focus on pulmonary vascular development and vascular disease. Dan and Sushma will be focusing on mechanisms of right heart failure with Pilar as well, and myocardial regeneration. And then if we are able to recruit Allison Marsden here to work with Jeff Feinstein and others, we'll be doing a lot more work on refining some of the surgical approaches and interventional approaches we take to structural heart disease through cardiovascular engineering, simulation techniques. And then we also hope to expand in the area of cardiovascular genetics, where one of our fellows, James Priest, has already made some excellent contributions that are translational in their nature with high-risk patients who haven't been diagnosed at the time of birth. Thank you very much, and I hope you got a sort of sense for what we do from this quick tour.
Great. Thank you so much, Steve. And just to keep things going, maybe one short question if anyone has a burning question.
Steve,
Yes, Joe.
great talk. I wonder if you can give us some, some methods or approaches or some creative thinking how pediatric cardiology and adult cardiology could work together more cross-wise.
Yeah, right now I'd say what we've done, in my opinion, very successfully clinically is to develop together the adult congenital heart program. Alan and I together are on an advisory committee that meets monthly with our administrative group, as well as the leadership of the program. And in my opinion, that has been a very successful clinical collaboration. And I think it points to other populations of children who survive childhood diseases who are going to be in our combined system. And so from a clinical point of view, I think we've got a very good paradigm for that. Obviously, what we'd like to be able to do is to think about things we can do together from a research perspective as well. But clinically, I think we've got a wonderful paradigm that's been established in the last 2 years for collaboration.
Okay,
Thanks.
fantastic. Thank you,
Thanks.
Steve.
Copyright Stanford University, all rights reserved.